Good afternoon, everybody. It is a pleasure for me to share in this scientific meeting of General Medicine Department, Banha Faculty of Medicine, which is considered the potential father of the Banha Faculty of Medicine, under supervision of my dear colleagues, Dr. Muhammad Shawqi and Dr. Ayman Badr. And again, thanks to Novartis Pharmaceutical Company. This is the session of this company. The subject was Valsartan, the golden standard, SMART trial. Actually, it is a debatable subject about treatment of hypertension and the initial combination therapy, diuretic and or calcium channel blockers on top of RAS inhibition. The pattern of risk factor profile in Egyptian patients with acute coronary syndrome, 43% of male and 70% of female are hypertensive. وأنا بصراحة يسعدني إن أنا كنت واحد من investigator of this study that was published 2 years ago. Mr. Chairman, ladies and gentlemen, hypertension is easy to diagnose, but often remain undetected. Hypertension simple to treat, but often remain untreated. Despite the availability of potent antihypertensive drug, treatment is often ineffective in preventing the complication of hypertension. The pathophysiology of hypertension, mainly genetic predisposition with environmental factor. By genetic predisposition, the defect in sodium handling through renal tubules with inadequate sodium excretion, salt and water retention, increase in both plasma and extracellular fluid volume, and result in increasing cardiac output. The second mechanism due to the genetic predisposition is functional vasoconstriction with increase in vascular reactivity and vasoconstriction with total peripheral resistance increases. The third is defect in vascular smooth muscle cross and destruction and increase in vascular smooth muscle wall with increase in total peripheral resistance. Together with increase in cardiac output, there is increase in the level of blood pressure, which is known hypertension. As regards environmental factors, inappropriately high sympathetic outflow is the main target, with inappropriately high renal excretion and high renal release, with abnormal venous constriction and high venous return, increased sympathetic resistance, abnormal renal salt and water handling and retention with hypertension. In comparing RAS inhibitors, angiotensin receptor blocker shows the highest reduction in both systolic and diastolic blood pressure when compared to angiotensin converting enzyme inhibitor or to direct renin inhibitors. And in 22 clinical trials, more than 140,000 hypertensive patients. In this meta-analysis assess the effect of different antihypertensive groups on the incidence of newly onset diabetes mellitus. Angiotensin receptor blocker are the best in reducing the new onset diabetes, especially when compared to angiotensin converting enzyme inhibitors and to other antihypertensive group, and the highest is diuretics. Angiotensin converting enzyme inhibitor is not a safe and tolerable drug because the incidence of angioedema is clearly high and more than 1,000 individuals die worldwide per year from angioedema. Cough the incidence of irritative cough may reach up to 30%, especially in Asia, and that the amount of reduction of blood pressure decreases with time due to ACE escape phenomena. So for that reason, RAS blockade, which is the main pathophysiological mechanism of hypertension, especially with ARBs, can be considered as a foundation of antihypertensive drug, especially when combined with calcium channel blockers or diuretic or any other antihypertensive group. From angiotensin receptor blocker, valsartan has the highest affinity for angiotensin receptor 1 versus angiotensin receptor 2, especially when compared to the other member of angiotensin receptor blocker 10-mesartan, irbesartan, olmesartan, or losartan. And then valsartan has a wealth of cardiovascular outcome data, especially in the field of heart failure and myocardial infarction and proteinuria, which is reduced with valsartan, especially in diabetic patients. For that reason, the guideline recommends combining ARBs with either calcium channel blocker or diuretic, and states that a large body of evidence exists that combining an angiotensin receptor blocker with calcium antagonist or diuretics provide, first, effective reduction of blood pressure, second, high rate of blood pressure control in a variety of hypertensive categories, third, has a tolerability profile even more favorable than when an ACE inhibitor is used, and lastly, protect against subclinical organ damage. When comparing monotherapy with combination therapy as regards cerebrovascular disease and coronary artery disease, the combination therapy is more protective than monotherapy due to less side effect, good adherence rate, and more antihypertensive effect. And in these 10 trials, most patients require more than 2 antihypertensive groups to reach the blood pressure goal. And a considerable number of these patients need 3 antihypertensive group combinations to reach the blood pressure goal. However, the combination of antihypertensive group, when used separately in 3 pills, have a poor adherence rate when used in a single pen or 2 pills combination used as regard adherence rate, and then the control of blood pressure and the reduction of cardiovascular complication due to hypertension. Express-M study in comparing valsartan with amlodipine 5 mg versus amlodipine alone, there is a doubling of blood pressure reduction in the combination therapy compared to monotherapy with calcium channel blocker. Again, combination therapy of valsartan with calcium channel blocker have a significant benefit in reduction of cardiovascular morbidity, which may reach to 45% compared to calcium channel blocker amlodipine alone, and reduction of stroke transient ischemic attack, reduction angina pectoris above 50%, reduction in the newly onset diabetes. Again, the peripheral edema is markedly reduced in combination therapy versus amlodipine 10 mg monotherapy. The symptomatic hypotension in elderly is reduced about 0.3% and the non-elderly 0.4% due to combination therapy antagonizing the side effect of each other. However, triple combination of ARBs, calcium channel blocker, and diuretic have a higher antihypertensive effect, reduction of systolic blood pressure by 50 millimeter mercury, especially when compared to amlodipine valsartan alone or valsartan hydrochlorothiazide or amlodipine hydrochlorothiazide. So, triple combination have a high level of blood pressure lowering compared to any dual antihypertensive combination therapy, whether ARBs with calcium channel blocker, ARBs with diuretic, calcium channel blocker with diuretics. For that reason, SMART trial, which is the first Egyptian trial, and Oxford HCTL. Oxford HCTL, as you all know, it is valsartan 160, amlodipine, and hydrochlorothiazide with two dosage. First, patient in uncontrolled or dual therapy. The title of the study that was published in the last years, Efficacy and Safety of Amlodipine, Valsartan, Hydrochlorothiazide, Single Pill Combination, means good adherence rate, in Egyptian patients with hypertension uncontrolled on any dual therapy and observational study. The SMART study, the object of the study, as I have mentioned now, current study aim to evaluate the efficacy, not only efficacy, but also tolerability of Oxford HCTL in single pill combination in patients with hypertension from Egyptian population who were uncontrolled on any dual therapy. This study included more than 1,000 patients from 47 centers all over Egypt. It was an able-label observational multi-center full authorization prospective study. 2 doses in single dose. First dose, 5 milligram amlodipine and 12 milligram hydrochlorothiazide in addition to a fixed dose of valsartan 160. High dose Oxford, 10 milligram amlodipine, 25 milligram hydrochlorothiazide, 160 milligram valsartan. Up titration of the dose was allowed, according to the physician opinion, to control the blood pressures. The duration of the study was 12 weeks. Inclusion criteria, patient age above 18 years with hypertension that were uncontrolled systolic and diastolic blood pressure more than 140 and over 90 on any dual antihypertensive combination. And exclusion was a contraindication in pregnancy and lactating women and or women of childbearing potentials. The aim of the study, first, primary efficacy, primary endpoint, mean change in blood pressure after 12 weeks of treatment with single pill combination on either doses, 5 milligram or 10 milligram amlodipine of Oxford HCTL. Secondary endpoint, mean change in blood pressure after 12 weeks of treatment, or after 2 weeks of treatment, blood pressure control rate, and change in heart rate, and finally compliance with single pill combination at the end of the study means 12 weeks. Safety and tolerability, especially ankle edema or any adverse event which can occur, and that especially necessitates withdrawal of the drug, and finally the tolerability of the drug and the adherence rate to the end of the study. The baseline blood pressure was 165 systolic blood pressure mean and more than 100 diastolic blood pressure mean as the baseline for the study. As a result, there is a significant reduction in both systolic and diastolic blood pressure from the start within 2 weeks, which may be maximized at the end of the study to reach about 36 millimeter mercury systolic reduction and 20 millimeter mercury diastolic reduction at the end of the study, as that to say, by the end of 12 weeks. And 79% of the studied, about 800 patients reached systolic blood pressure below 100 millimeter mercury, and 92% of patients has the systolic blood pressure below 90. Overall, blood pressure reaching goal with systolic blood pressure below 100 and diastolic below 90 is 77%, which is mean that 8 out of 10 patients reach the blood pressure goal, which is a high level, which is significant. Again, 96% of the patient showed good and excellent tolerability of the X4 with the drug X4 HCTL without recorded side effect or adverse effect that necessitate withdrawal of the drug. The study conclusion is that in this observational study, X4, which means triple combination single pills, amlodipine, valsartan hydrochlorothiazide, whether in small low dose 5 mg amlodipine or high dose 10 mg X4, amlodipine significantly reduced blood pressure in patients with hypertension in Egypt, especially in non-controlled on any previous dual therapy. X4-HCC also showed a significant improvement in blood pressure, with a majority of patients achieving blood pressure goal below 140 systolic and 90 millimeter mercury diastolic at the end of the study, which means 8 out of 10. 96% of patients showed excellent and good tolerability of X4-HCT. The guideline accordingly reported that among all patients with hypertension, ACE inhibitors, ARBs, beta blocker, calcium channel blocker, and diuretics, thiazide and hydrochlorothiazide, and indapamide have demonstrated effective reduction of blood pressure and cardiovascular event in randomized controlled trial, and thus are indicated as a basis of antihypertensive treatment strategy. And that combination treatment is recommended for most hypertensive patients as an initial therapy. Preferred combination should compare RAS blockers, either an ACE inhibitor or ARBs with calcium channel blocker or diuretic. Other combination of the 5 major classes can be used, class 1, level of evidence A. And finally, it is recommended that if blood pressure is not controlled with the 2-drug combination, treatment should be increased to 3-drug combination usually, and recommended RAS blocker with either ARBs or ACE, with calcium channel blocker and thiazide, preferably in single pill combination, which is most important for good adherence. In these figures, patient with coronary artery disease is recommended initial therapy ACE or ARBs plus beta blocker and calcium channel blocker, mainly non-dihydropyridine and or diuretic. A second step, the above combination. In kidney disease, ACE or ARBs with calcium channel blocker, or ACE with diuretic, mainly loop and calcium channel blockers. For uncomplicated hypertension, ACE, ARBs, calcium channel blocker, or diuretic, or the combination of both, and also prefer to be single pill combination. Heart failure with reduced ejection fraction, ARBs or ACE with diuretic and beta blockers. Hypertension with AF, ARBs or ACE beta blocker, or non-dihydropyridine to be negative chronotropic effect with calcium with diuretics. And finally, Mr. Chairman, ladies and gentlemen, hypertension is definitely easy to diagnose and easy to treat. And the aim of the management is to save the target organ from deleterious effect. The pharmacological armament of antihypertensive drug is so rich that we have a wide range of options. This makes the physician comfortable in different situations. Physicians need to be careful regarding the choice of the drug. Primary prevention of hypertensive complications should be highlighted and should get more priority. Valsartan combined with diuretic and amlodipine showed a significant improvement in blood pressure control, with a majority of patients achieving blood pressure goal 100 systolic and 90 blue 90 diastolic. Valsartan combined with diuretic and amlodipine as calcium channel blocker showed excellent and good tolerability and safety. And finally, thank you.